So good day to you all. It's a great honor to speak on the British Ukrainian Symposium on Anesthesiology, Intensive Therapy and Pain Medicine. My name is Hans de Boer. I'm an anesthesiologist and pain specialist from the Martini General Hospital in Groningen. I will talk today about ANI and ERAS, a new promising combination. These are my conflicts of interest, and this will be the agenda for today. I will talk about the ERAS philosophy, traditional monitoring of surgical stress, the analgesia nociception index, ANI in clinical studies, and draw some conclusions. So the ERAS philosophy. When we look at the cornerstones of ERAS, this is our evidence-based perioperative care. It's multidisciplinary, a multi-professional approach. It's teamwork, and important, the continuous interactive audit and reporting. And it is data-driven change, and also the readiness to make the change. And these are all the ERAS elements, for instance, for colorectal surgery. All the items applied in one pathway, integrated as an ERAS protocol, from pre-admission to the follow-up of 30 days. And importantly, the interactive team audit and audit of the outcomes and compliance. So we focus on the patient by following the patient's journey. And ERAS is also a multidisciplinary team approach. It's about a surgeon, the anesthesiologist, the high dependency unit specialist, PACU and ward nurses, but also anesthesia nurses, physiotherapists, dietitians, and management. And this team is going to train, implement ERAS, do some planning, auditing of the outcomes, updating when something is new, and reporting. And also a multidisciplinary team approach is doing research to get more knowledge on ERAS. And it starts out with the ERAS Society guidelines. What do they preach? They preach a multimodal approach, reduce stress, support function, and a reduction of complications. In fact, it's better care for less costs. So let's take a closer look. This is a table where more than 36 ERAS Society guidelines are presented. And more you can see on our website. You can download our protocols for free. So ERAS results in stress reduction. This was also done very early days of anesthesia. With balanced anesthesia, we had a Liverpool technique. And finally, we came out that reflex depression benefits the patient. And this is done by multimodal analgesia or anesthesia. And this is really a paradigm shift in perioperative medicine. So the impact of surgical stress and concomitant inflammation and the control of nociception. That's the key issue. But how to monitor surgical stress, which leads to postoperative pain, for instance? This is the quest of the Holy Grail. Let's take a closer look to the traditional monitoring of surgical stress. We have the clinical parameters, which means increased heart rate and blood pressure, a moist or sticky skin, cold skin, hyperventilation or an increased airway pressure, lacrimation, dilated pupils, we know, change CO2 concentration, but also decrease the minimum alveolar concentration, and so on. You can read them all. But then the question mark, what does this mean? Actually, clinical signs are useless to predict postoperative pain and recovery. So let's take a closer look, because pain is a subjective feeling, a perception. Nociception is not a subject feeling, but a physiological encoding and processing of nociceptive stimuli. And monitoring nociception remains a challenge in attempts to lower the incidence of acute postoperative pain. So the big question is, can we monitor this in a more sophisticated and objective manner? This brings us to the discussion of the analgesia nociception index. But before, I will show you the anatomy of surgical stress response. It starts all with the first incision stressor. You have local tissue injury, and there comes a whole cascade of different parts which are activated. It goes up in the peripheral efferent pain nerve injury. It goes up to the spinal thalamic tract. Neurotransmitters are involved, but also anesthesia stressors. And this results in neuroinflammations, for instance, but also in the brainstem, a disbalance between the parasympathetic and the sympathetic outflow. Coagulation is involved, but also inflammation is a big part of surgical stress. So actually, the patient is in a whole body and organ dysfunction. But let's focus on the brainstem, the balance between the parasympathetic and the sympathetic outflow. Normal in humans, there is a normal balance between nociceptive and the anti-nociceptive balance, sympathetic and the parasympathetic. So the response to surgical stress is an increase in sympathetic activity or the corresponding decrease in parasympathetic tone. But how can we translate surgical stress to a parameter which can be monitored? And what we know is that surgical stress influences the heart rate variability. And this is not new. Heart rate and heart rate variability is all across our history. We also have it in our mobile phones, for instance. When we're doing sports, you can see your performance in your app at your telephone. And heart rate variability is not new, as I told you. This is an important editorial view of 1999. And Thomas Egbert here said that preliminary data have suggested that low heart rate variability, an index of impaired cardiac vagal tone, is an independent predictor of mortality after non-cardiac surgery. So let's take a closer look about the physiological fundamentals. Sinus respiratory arrhythmia is the variation beat to beat of the distance between these two beats due to ventilation. It guarantees optimal oxygenation of blood, and it is mediated by the vagal nerve loop, thalamus, and the ambiguous in the autonomic nervous system headquarters. That detects the pressure on the lungs. No nociception, the parasympathetic acts creating this arrhythmia. So nociceptive stimuli present, it blocks parasympathetic activity and the arrhythmia disappear. So we can measure when nociception occurs with heart rate variability. And this is actually what's being done. Through a very difficult formula, ANI can be calculated, where 0 is the maximum nociception, sympathetic, and 100 is the maximum anti-nociception, which is parasympathetic. So in anesthetized patients, decrease in ANI values during nociception, adults and in children, before hemodynamic reactivity, and ANI allows for prediction, intraoperative hemodynamic reactivity, and immediate post-operative pain. It's a very sensible calculation. Let's take a closer look. What you also can do with this is to measure the energy, how much variability present from beat to beat. Higher energy means a more powerful autonomic nervous system, which is actually lower in elderly and weaker patients, and it's higher in young and trained patients. So we will come back on this a little bit later. So the analgesia nociception index technology, it is a monitor the parasympathetic tone. Parts of the autonomic system, the ANS, comfort or discomfort of the body, and the occurrence of pain or stress that from surgery. So, and this is actually what you can see in practice. So 100% is a maximum anti-nociception, parasympathetic, and 0 is the maximum nociception, sympathetic. And you have a right balance between 50 and 70. But are you above from 70 to 100, you might decrease the anti-nociception a bit. But when you go lower than 50, you need an increased anti-nociception. and also a risk management of hemodynamic events. And antinociception, we have a whole armamentarium in our profession to use as an antinociception. That starts from opioids, ketamine, alpha-2 agonists, magnesium lidocaine, dexamethasone beta blockers, paracetamol, NSAIDs, and epidurals, blocks, or local infiltration techniques, for instance. So when you're out of the balance and you are below 50, you need to do something in the pathway of antinociception. So what about this in the clinical setting? So let's go to some clinical studies. This is an important study from 2017. Is the validation of the innovative techniques for monitoring nociception during general anesthesia. And this article, in this validation article, it says that the changes in analgesia nociception index and surgical platysmo index, as well as the pupillary dilation, were sensitive and specific for painful stimuli. And when you look at the sensitivity and the specificity, it's important to recognize that ANI has a high sensitivity and specificity, higher than heart rate or mean arterial pressure or values you derive from this. This is another important study. The intraoperative analgesia nociception index guided fentanyl administration during sevoflurane anesthesia in lumbar surgery. Patients receiving intraoperative ANI-guided fentanyl administration during sevoflurane anesthesia for lumbar surgery demonstrated a decreased pain in the recovery room, likely as a result of more objective intraoperative fentanyl administration. And this is also an important study, published in 2015 in the British Journal of Anesthesia, the post-operative pain assessment in children. This was a pilot study of the usefulness of the ANI index. So this means that objective method to assess pain in children may help to direct postoperative pain control. The ANI, or the analgesia nociception index, is a non-invasive technique to measure autonomic variability. And the predictive value of the ANI is assessed for identifying postoperative pain in children. And the ANI was useful in predicting postoperative pain. Of course, it needs further studies in children. This was a very landmark study. But also we talked about the energy. This is a recently published paper in 2021. Is the heart rate variability monitoring using the analgesia nociception index a predictor of illness, severity, and mortality in critical ill patients with COVID-19? This was a very nicely pilot study. And it showed that low autonomic nervous system activity due to the sympathetic depletion in COVID-19 patients are associated with worse prognosis, higher mortality, and higher interleukin-6 levels. So also this is a very nice technique to see stress, not from surgery, but from illness. In this case, it was a severe ill patients in COVID-19. So in conclusion, the monitoring of nociception is a relatively new science and a non-invasive promising technology. Heart rate variability is an ideal option to detect sympathetic parasympathicus disbalance and the occurrence of pain or stress that from surgery. ANI is based on monitoring of the parasympathetic tone as part of the autonomous nervous system. And ANI shows value in the ERAS philosophy, as ERAS philosophy showed that you reduce surgical stress. And an ANI threshold of 50 is identified as predictive of acute postoperative pain, NRS greater than 3, with good sensitivity, 86%, and specificity, 86%. ANI is capable of detecting noxious stimuli with a higher sensitivity than clinical parameters like heart rate or blood pressure. And ANI greater than 60 should decrease the rate of hemodynamic episodes. Thank you for your attention, and I wish you a very successful Congress.